Schizophrenia. Etiology and psychopathology. Schizophrenia is currently believed to be a neurodevelopmental disorder. There is strong evidence of genetic risk, e.g., identical twins have a 48% chance of concordance. Structural changes seen in MRI studies include decreased volume of areas such as the parahippocampus, thalamus, superior temporal gyri and frontal lobes. Older neurotransmitter theories focused on defects in the dopamine system, but newer theories include defects in glutaminergic neurotransmission involving hippocampal N-methyl diaspartate receptors. Epidemiology. Prevalence: 0.5 to 1.5% of the general population. Incidence: 0.5 to 5 per 10,000 per year. Median age at onset: early to mid-20s for men, and late 20s for women. Clinical presentation. An important aspect of schizophrenia is its devastating effect on an individual's interpersonal relationships, work, self-care and other goal-directed behaviors. The diagnosis of schizophrenia requires the presence of 2 or more of the symptoms for at least 1 month, and the total duration of the illness, including prodromal and residual symptoms, should be 6 months or longer. Core symptoms of schizophrenia: delusions, false, unshakable beliefs held with extraordinary conviction that are not amenable to logic, and out of keeping with the patient's social, cultural, and educational background. Hallucinations, a perception experienced in the absence of an external stimulus to the sense organ involved, most commonly auditory. Disorganized speech, loss of normal structure of thinking. Negative symptoms: blunted affect, apathy, poverty of speech, attentional impairment, poor motivation. Disorganized behavior, excitement, stupor, and mutism. Take care to exclude mood disorders, substance abuse and general medical conditions. Differential diagnosis. Other disorders presenting with schizophrenia-like symptoms include the following: schizophreniform disorder, symptoms present for 1 to 6 months. Schizoaffective disorder, concurrent mania or severe depression. Delusional disorder, encapsulated delusions with minimal hallucinations. Brief psychotic disorder, duration less than 1 month. Shared psychotic disorder, folie à deux, a person without psychosis taking on the psychotic symptoms of someone close. Due to general medical condition, e.g. high-dose steroids. Substance-induced, e.g. amphetamine intoxication. Treatment. This is a complex illness that needs a comprehensive treatment approach. Always obtain collateral information. Physical examination and special investigations are needed to exclude concurrent medical problems. A useful approach to treatment is to use the biological, psychological, and social guidelines. Biological: antipsychotic medication. Psychological: cognitive therapy. Crisis management. Social skills training. Social: family therapy. Vocational rehabilitation. Psychoeducation, e.g. recognizing early signs of relapse. NB. High expressed emotion, i.e. criticism, hostility, and over-involvement of parents or caregivers towards people with schizophrenia is a significant risk factor for relapse. Complications. NB. Suicide. Of patients with schizophrenia, 10% die by suicide and up to 50% attempt suicide. Prognosis. Prognosis is variable and difficult to predict for any individual. Estimates are as follows: 10 to 15% have a good prognosis. 10 to 15% have a chronic, unremitting course. The remainder vary from occasional to frequent relapses. Predictors of a poor outcome include the following: male sex, obstetric complications, abnormal premorbid personality, low IQ, single, early age at onset, insidious onset, substance abuse, family history of schizophrenia, absence of obvious precipitant.